Okay, good morning, everybody in US, and good evening, all my colleagues in China. So C3, as you know, because of the COVID-19 situation this year, the live meeting will not be able to be conducted. So C3 is providing education virtually, and in several different series that C3 will put up. Virtually, this is a very important series of COVID-19 and C3 on the front line. So today's session is to get the Chinese experience of COVID-19, and to moderate this session, it's my great honor and privilege to have Dr. Professor Yuji Zhao from Beijing Anzhen Hospital, as well as Dr. Wai Lu, who has helped us put this session together and has invited several of his colleagues from Wuhan, as well as from Beijing, who are involved in the front line of treating COVID-19 patients, as well as explaining us, the potential cardiac implications and vascular implications of COVID-19 that we can learn from Chinese experience. So I'll turn it over to Dr. Zhao and Dr. Wai to introduce your colleagues, and then we'll get started.
So thank you, the C3, the committee chairman, the Professor Dao, to organize this very special session. So we are invited the Chinese, the doctor, the hero, Dr. Ge, Dr. Du, Dr. Zhou, Dr. Wang, to we are our Chinese the doctor, the hero. So Dr. Liu Wei and me to support this kind of the pretend the COVID-19 the action in the Beijing. So this time we are together to talk about experience about China to attack this COVID-19 this action. So we conquer this battle. We get success. So many provinces to recover to normal. To now, in the Beijing, to our hospital to beginning to this week maybe recover to normalize the worker. So we're very glad to talk about this kind of about every doctor to a very special experience. So first, I want to introduce the Dr. Zhou, to introduce the Chinese the Frontline. So Dr. Zhou, about
so we have now
fight on the first line and COVID-19 in Wuhan, implication in cardiovascular medicine.
Great.
First.
Okay, I'm ready. So thank you so much for Dr. Zhou, Dr. Dave, and Dr. Clark and other Chinese colleagues. It's my great honor to have me here. I would like to share my screen first. Hello everyone, my name is Lim Zhou. I'm from Tongji Hospital, Wuhan. And this is my self-introduction as introduced by Professor Yujie Zhou. And this is my hospital. My hospital named Tongji Hospital was located in Wuhan. It was founded since 1900 by a German doctor. So our hospital has a lot of the communications with Germany academic field. And we have 3 campuses, 60,000 beds, 10,000 medical personnel, and 62 clinical departments. Our hospital is also ranked as a top 10 in China. As you know, that our city, Wuhan, was the epicenter of this COVID-19 epidemic. My city is very located in very center of China, has a population of 12 million, and because it's very center, so it's a commuter area of China. Due to the outbreak of epidemic of COVID-19, it was locked down on January 23. As you know, that everything is closed, everything is blocked. Nobody can enter and nobody can go out of the city since January 2023, and it's already lived 2 days ago. So far, we have over 80,000 accumulated cases confirmed in China, and unfortunately, we have over 3,000 deaths in China so far. Most of the cases came from Wuhan. We have over 50,000 cases and over 2,500 cases in Wuhan. And the mortality rate of the COVID-19 in China is around 4 to 5%. And unfortunately, we have over 3,000 of the medical staff that was infected in the epidemic and 61 deaths. So the death rate of the medical staff is around 2%. So I would like to share some of the clinical characteristics of the patient in China. So this data came from the Journal of JAMA, published in January by Dr. Zhong Nanshan. And somebody says that the COVID-19 can only affect the old elder. We're sure that's not true, right? So from this data, we can see that aged from 0 to over 65, all of the population are very easily to be affected by this COVID-19. And most of the cases come from this range, age from 15 to 65. That means most of the patients was aged in this range. And most of the cases are male, and the median incubation period is around 4 days. That means from the infection to the onset of symptoms, that's 4 days. And this is the clinical symptom of the patient. The most common is the fever. So around half of the patient have a fever, but the body temperature was not so high. It's around 37 to 39 around. And most patients have a cough, has dry cough and headache, and also has a fatigue and sputum. If the patient have a shortness of breath, that's not good signs. It usually means that the patient has developed into from a mild to a very critical condition. So that's a very dangerous signs. And this is signs of infection is very is not so common. And I mean, most of patient, not most patient, some patient have a coexisting disorder. This is for general cases of COVID-19. For those who has a very severe or critical severe type, the coexisting disorder is much higher than this proportion. For our cardiologist, we are very interested in the cardiovascular disease of the patient. For example, diabetes, hypertension, and coronary heart disease. Almost 15 of the patients have a hypertension was infected. Among all of these patients, the hypertension is around 15, and the coronary heart disease is 2.3. So this is not so high because these cases, including all of the mild, moderate, severe, and the critical severe type of the patient. So it's not so high. I will show you the data in the next slide. So this is the complication of the patient, the ARDS and the pneumonia. Most of the patients have a pneumonia, and the death rate is only 1.4%. All of us, we know that this is not true because this is in the very beginning of the epidemic. So far, the death rate is around 4.5% in China. So these two videos showed the radiological findings of the COVID-19 patient. These two, absolutely, this is very severe. It's a very severe type of the COVID-19. We can see that the bilateral patch shadowing and the interstitial abnormality in both lungs. So these two patients are very severe. And also this is a summary from another report, including more cases, was published in Lancet. So 72,000 patients was included in this research. We can see that the age distribution of this patient is aged from 30 to 80 years old. That is almost 90% of these cases in this age. And 81% of the patients are mild. That means no pneumonia and no symptoms, sometimes no symptom, just maybe a fever, cough, and fatigue. But for the other patient, is around 20% of patient is severe or critical. That means the patient have a short of breath and respiratory failure, even a septic shock, and need the ventilation. So the case fatality rate is around 50 in the critical cases. Oh, that's a very, very terrible number, right? That is very high. So, I mean, half of the critical cases will die from COVID-19. And 50% of the patient older than 80 years old will die. So these two part of the patient are very dangerous. Most of them will be treated or monitored in the ICU ward. And this is a matter of great concern for our medical personnel, because look, 3.8% of the patients are medical care personnel, and 63 was confirmed in Wuhan, because this is the epicenter of China, and around 50% cases was classified as a severe, critical severe type. So this is another data from the New England, and here we showed the patient died from COVID-19. Also, most of these patients was treated in the ICU. Around half of them have hypertension. I mean, these patients are critically severe patient. So half of the patient have hypertension, 31% of the patient have a diabetes, and around 24% of patients have a coronary heart disease. This coexisting disorder in the very critically severe patient is very, very high. And the troponin I, we found almost half of the died critical ill patients have a very high troponin I levels. So that means if the patient have a myocardial injury, that's not a good sign for the patient. The prognosis or the outcomes of this kind of patient are very bad. And this is our data. We showed the differences of the phenotypes of patient with a positive or negative troponin I. Here shows that the patient have a positive troponin I is much older than the negative one, and most of them are male. And the proportion of the positive troponin I patient is around 20%. And also the mortality rate of this kind of patient is around 90%. It's much higher than the previous one. So, I mean, if the patient have a very severe myocardial injury, that's very, very bad for this patient. And for this troponin I positive patient, the BMP is really, really high. And this is the survival curve for those who have a positive or negative troponin I. Here we showed the 14 days in hospital mortality for those troponin I positive patient is much lower, is getting worse and worse. And for those patient positive or negative troponin I, this is data of 30 days in hospital mortality is much worse than the negative one. So our experience for the management of the COVID-19, we have two experience actually. First one is to test all of the confirmed cases, test all of the highly suspected cases to find out the source of the infection, and then to isolate them to cut off the path of the infection. So to find the source, to cut off the path, that's the most important two method to end this epidemic. So that's what I think. So the treatment for the COVID-19, as we don't have very specific and effective treatment for the very severe COVID-19 patient. The general treatment including the rest, the monitoring, the oxygen therapy, and some traditional Chinese medicine. So here I showed a link. I will show a Chinese clinical guidance for COVID-19 pneumonia diagnosis and treatment. This is a 7th edition published by China National Health Commission on March 4. I think that's a very good references for the world. And this is very regular antiviral drugs we used in the treatment of COVID-19. But actually, all of us know that we don't have very solid data and very solid evidence to show that some kind of the antiviral drugs is very specific and effective for the coronavirus. And around 20% of the coronavirus, COVID-19 will develop into a severe or critical severe. So we have a standard for the critical severe type. First one is respiratory failure, second is shock, and third one is the patient need ICU monitoring and with the other organ failure. So for those very critical EO patients, we most commonly used method is the ventilation, including the invasive and the non-invasive ventilation for this patient. But what if the patient still have very severe hypoxemia on ventilation? So our answer.
All right.
Sorry. Can I go on? Oh, okay. The treatments, yeah. So this is the treatment for very severe or critical severe patient. So firstly, we need absolutely we need the respiratory support, including the intubation and the ventilation. And also for some patients, we need the immunotherapy like the systemic steroid and blood purification, and also including the circulation support like ECMO. So I'm going to go through very quickly of a critical EO case, just a few minutes. So this patient is 50 years old, is a male, 50 years old, admitted on February 11. And this is the complaint and the medical history, and this past no very special past history. And this is the chest CT scan, and this lab test. This patient have a very very lower lymphocyte proportion. So this is a very important biomarker for those patients who will develop from a mild to a severe type. And also we found a very higher NT-proBNP and troponin I for this patient, and a very lower ejection fraction. That means the patient have heart failure due to their COVID-19. So we give some very regular treatment for him, but the hypoxemia was getting worse and worse, and then he was transferred into ICU. This X-ray showed just 2 days before he was transferred. And we give some additional treatment in the ICU, including the intubation and the ventilation. We give the mechanical ventilation for him, and also we use the prone position ventilation. But his oxygenation index is still very low. We know that for normal persons, the oxygenation index is around 300 to 400, but his is only 95 millicuries, so it's very low. So it's a very dangerous condition for him. And at that day, the February 18, we did the ECMO for him. That's a VV ECMO. This is initial parameters for him. And this picture just taken just a few minutes after the implementation. And look, this picture shows the SpO2 is getting much higher than the before the implementation. And these two videos showed the CT scan of the lung before and after the implementation of the ECMO. Look, this is very severe. Both lungs have a very severe lung lesions, but after that, it's getting much better. And we also test the coronavirus and the antibody. The antibody IgG is positive, and the virus test is negative. And this just he was discharged on March 20. And so this is summary of these cases during the stay of the hospital, and this duration of the ECMO. And this X-ray and CT scan images showed that his lung lesion is very bad on admission, and getting much better after his before his dischargement. So far, we have finished 5 cases in the ICU ward of my hospital, or 4 cases already finished, and still 1 is ongoing, 4 male and 1 female, 4 VV ECMO and 1 VA ECMO. And the age is around 55 years old. The average duration of the ECMO support is 9.2 days. And before I finish, I would like to say thank you to all my patients, because my patient, they are the hero of these cities. Unfortunately, they were infected by the coronavirus, but they fight against the coronavirus with their bodies together with us. We fight against the virus with our technique, with our drugs, with our treatment. We stand together. So they are the hero of the city. And thank you so much for your attention. That's it. Thank you.
Thank you, Dr. Zhou.
presentation and a lot of learning that was just put out. The two things that, are really striking that, such a large number of healthcare workers were infected, in the treatment. They are certainly our heroes, and some of them actually did die. And I also was stunned by, patients, those who have high cardiac troponins and high BNP, their risk of death is substantial. And it's impressive to see the improvement with the ECMO in this patient. Dr. Cluck has joined us from Allentown now. Brian, can you hear us?
I can. Can you hear me?
Yes, we can. Yeah.
Excellent. Sorry for the technical difficulty.
Yeah. So it seems like, Dr. Cluck is in a big hospital system in Allentown. They also have a fairly large number of COVID patients now. Brian, do you have any patients with ECMO in your hospital right now?
Right now we have one. Our ICU has 10 or 11 patients in it at this point, on ventilators, prone position with 10 to 15 a PEEP. And there is one patient that's on ECMO at this time. So
yes,
we're just
we'll discuss about the PEEP a little bit, because one of the things that, I've been reading about is that the PEEP may not be so useful because it's not a issue of, compliance of the alveoli. It seems like it's more of an issue of oxygenation. So by giving them a lot of PEEP, maybe we are damaging their lungs and may not be helping them with a full oxygenation. But, the early ECMO insertion may be better than a late insertion, but I think, the Dr. Zhao may, have more to say about, is there a threshold that you use about when you insert ECMO?
Yeah, I mean, there's the opportunity or the time of the implementation of ECMO is the most important for those very critical ill patients. I always say that it's better to use ECMO for the patient who have a very severe hypoxemia but has no MODS, I mean the other organ failure. Before the liver failure, the heart failure, and the DIC. Before that, you use ECMO for him. That's much better. So I always said that better is earlier is better. If you meet a method standard.
No, that's absolutely, very useful. Okay, now I'd like to, Dr. Zhao or Dr. Wai, like to introduce Dr. Yushi Wang now. Yeah.
Dr. Wang Yushi. Yeah. Dr. Wang Yushi is used to be my, Dr. Wang Yushi is chief physician from Jilin University, the first teaching hospital, the biggest hospital from Jilin province. And she came to Wuhan with her team on February 10th to help the Sino-French United Hospital in Tongji Hospital. So she gained a lot of experience in treating very ill patients. And she's going to give us a lecture about very severe case of COVID-19. And let's welcome Dr. Wang Yushi.
Great. Well, welcome, Dr.
Okay.
Wang. It's great to have you. And go ahead.
Okay. Hello, every professor and cardiologist in First Hospital of Jilin University. About 60 days ago, I came to Wuhan. The first hospital I worked is Tongji Hospital. There, we received about 60 severe COVID-19 patients. That means their peripheral oxygen saturation is less than 93% when inhaling air. Here you can see the majority of the patients are old people. All the critical and died people are from the old people. So the age is the single negative prognostic indicator. And another one is underlying conditions, such as hypertension, diabetes, or coronary heart disease, who suffer from such kind of disease. They are supposed to be critical one. Another one is troponin and the BNP. Troponin and the BNP will be increased when cardiac involved. The risk of death will be increased obviously. Another one is lymphocyte count. Generally, the most of the COVID-19 patients, the lymphocyte count less than 10%. Another is the dimer, especially in critical COVID-19 patients. They have coagulation dysfunction, so their dimer will be getting higher and higher, even to the topest limit. Another one is inflammatory factor, such as interleukin-6. That means there is a systemic inflammatory reaction in COVID-19 infection patients. Here I want to introduce the isolation ward. From this entrance, we will enter the contaminated district. This is the first door. And then this is the first room. Here we have to take on the high quality personal protective equipment, such as caps, goggles, and clothes. And this is the passage. We will enter the isolation ward. Also, when we get out from the ward, in the there are separating rooms. The first room, so the same passage. This is the ordinary ward. Here I ask history. And here all of
I think we may have lost her.
Yeah, I think she.
sorry.
Yeah, that's okay. No
The
problem.
wire is not. Sorry,
Okay.
the wire is not very stable.
Yeah,
Yeah.
no problem. No problem. Yeah.
No problem. Yeah.
So, this one is these patients are in their convalescent stage. Before their discharge, we talk about some points of for attention. And this one is
Professor
the
Wang. Professor Wang,
okay.
please,
Yeah.
please put your slide.
Like
Please
to transfer it online.
Your slide. 你的幻灯。
Share the
We're
screen.
trying to see your slide.
Okay. You didn't see it?
Yes. Your upload again.
You can
就再
share
Okay.
slide.
再上传一遍，
Okay.
就是刚才你掉线了，然后你那个屏幕就掉了啊。
Yeah, we got it. Yeah.
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 Yes. It's
Okay.
okay.
This is the ICU, which was reconstructed temporarily. Here, the patient had a hypercapacity. So I modulated the ventilator parameter, and he had dyspnea for 1 week, accompanied with fever and cough.
I think Professor Wang's connection is not so great.
Yeah, Professor Wang just finished her missions in Wuhan and went back to Jilin, and they were quarantined in a mountain. It's called Changbai Mountain. So the signal is not very good because Changbai Mountain. Yeah, they were quarantined there.
Wow.
I think that's the reason.
Well, I'm glad that she's doing well. Yeah.
Again.
Yeah.
So yeah.
The wire in this hotel is not very good.
Right.
Yeah.
we can see that. Yeah, we can see.
Yeah. Because she's now in Changbai Mountain.
Now I can see well. Yeah, now we can see well.
Okay. This patient at the beginning, he had respiratory failure. So we use non-invasive mechanical ventilation because he can expectorate and clear the sputum by his own. And the parameter of non-invasive mechanical ventilation is not very high. So although he needs enteral nutrition, that means he cannot wean from mechanical ventilation even when he eats. So we use enteral nutrition. And besides antivirus, steroid, intravenous immunoglobulin, and antibiotics, after 30 days, we weaned successfully from the ventilator, taken after he weaned from the ventilator. Also, we can see the residual opacity and a lot of fibrosis, but afterwards he recovered totally. This one is the case 2, a female, 68 years old, fever and cough for 1 week. Past history, she suffered from COPD, and the CT scan is typical, but we didn't keep the CT scan, so I can't show it. And PCR is positive, so she was diagnosed as COVID-19. And in the white blood lymphocyte very low, and NT-proBNP and troponin is very high, and including the D-dimer also very high. So after the antivirus, antibiotic, steroid, and the immunoglobulin, and the non-invasive mechanical ventilation, and the oxygenation cannot be maintained. So we intubated her, but after intubation, cardiac arrest happened. So you can see the EKG is normal. So although the troponin is very high, we didn't see any change of demand ischemia. So I think it's a kind of systemic inflammatory reaction. This is the case 3. This is a female, 73 years old, fever and weakness, accompanied with cough and chest tightness. Also, her husband died of COVID-19. And then she was transferred to the first hospital in Wuhan, and they used non-invasive mechanical ventilation and antivirus and antibiotic. But her oxygenation cannot be maintained in normal range. So she was intubated, and at the same time, was on ECMO. On March 16, she was transferred to Pulmonary Hospital in Wuhan. When she came in, she was on sedation and analgesia, also mechanical ventilation and ECMO, including internal nutrition. When I left Wuhan, she was already on mechanical ventilation and ECMO for 40 days. This is the ECMO. The flow is 3.8, and this is the mechanical ventilation. We can see the pressure, the control pressure is 20, and PEEP is 8. The tidal volume only 170. So after we sedation and measure her lung compliance, only 6. So that means a lot of fibrosis present in her lungs. But vital signs are very stable. And the ABG is also almost normal. But only the lung compliance is normal. So although after 40 days, we do hope she can recover. She can wean from the mechanical ventilation and the ECMO. As a summary, I think we should pay more attention to the negative prognostic indicators, and maintain the normal oxygenation is the most significant treatment. Protect heart and monitor hemodynamic is very necessary, especially for the older patients who suffered from underlying conditions. And recommend the strategy of life support as early as possible as the presenter.
That is a superb presentation.
That's all.
Yeah, so can I ask a question?
Please.
Okay.
So I'm interested in particularly this last patient that had both mechanical ventilation and ECMO for a prolonged period of time. Do you think that the ECMO alone would be able to support her oxygenation, and mechanical ventilation could be stopped for the purpose of secretion clearance and that sort of thing? Is ECMO alone able to bear the burden of oxygenation?
You mean only ECMO is enough?
Not in the peak time, but let's just say this last patient was on ECMO and mechanical ventilation for 40 days. As you begin to wean, is it reasonable to leave the ECMO on and more rapidly wean the ventilation and get the tube out? And is ECMO enough in that circumstance to maintain the oxygenation? I would imagine it would be easier to clear secretions once the patient is extubated and have them cough.
To be honest, we didn't try to wean the mechanical ventilation because if the patient was on ECMO for so long time, we always need the sedation and analgesia. So without mechanical ventilation, we cannot use so high dose sedation and analgesia. And also the mechanical ventilator, the parameter, the condition is not very high. The tidal volume is very low. So we use the protective ventilation strategy.
I see.
Yeah.
Okay.
It seems like that her prognosis, is going to be not so good, given that she has such a, large device, in her for 40 days, that leads her to potential, complications of infection and limb ischemia due to the big cannulas, as well as, hemorrhagic complications. But, she seems to be very lucky that she's still alive. I would think that she should be dead by now.
Can I have a very short comment about the ECMO and the mechanical ventilation?
Yes.
Yeah, since we have 3 cases, the ECMO cases, and 5 cases, yes, 5 cases. And among them, we have 3 cases is awake ECMO. That means is the ECMO alone without the ventilation, or we wean off the ventilator first and keep going the ECMO for another few days. So that's what we did in these 3 cases. And I think for those very young patients, not so old, I mean 50, less than or younger than 60, I think for this patient whose lung lesion was not so terrible, I think the awake ECMO might be the better choice for them instead of the intubator and ventilation.
That's what I was asking about. I had heard of this strategy and it seemed very appealing, but I wasn't exactly sure which patients it would be apropos and which ones it wouldn't.
Yeah. So seems like a young patient who has a less likelihood of vascular complications, we could consider that an ECMO only strategy without, giving them mechanical ventilation. If obviously in a very severe cases.
If I might then go back to I believe it was the second case where a patient had an extraordinarily high troponin, yet had an electrocardiogram which really did not show localized current of ischemia. The question for me, and the question I think that's very important to the cardiologists in the United States is, how does that patient triaged? Are those patients, is it enough to have a normal electrocardiogram or a non-localizing electrocardiogram to not take the patient to the cath lab, to not do a presumptive intervention?
Yeah, that's a great question. Because this patient, will 100% would get a cardiology consult in US, and I'm sure that the intensivist will force the cardiologist to take a coronary angiography. Probably not required though. The coronary angiogram may not show anything.
Right, and that certainly is the strategy that we've been using prior to COVID-19. The question is, in the great experience that you professors have had, have you changed your strategy or altered it in order to avoid taking patients to the cardiac cath lab in large volumes? And what criteria do you use to do that or not do that?
Dr. Zhao or Dr. Wang?
Yes, there is some kind of protocol or some kind of consensus from Chinese Society of Cardiology. The consensus mentioned if the patient has acute myocardial infarction, the priority for this patient is thrombolysis instead of doing intervention for the purpose of protecting medical staff. So even the patient has typical acute myocardial infarction, we won't treat the patient with intervention, but thrombolysis. And from the experience of the doctors from the Wuhan, a majority of the patients who has increased troponin as kind of myocarditis-like findings. It's not due to the ischemic heart disease. So I don't think this kind of patient need a coronary angiogram. So and I had a few discussions with Professor Wang and also the other cardiologist from Wuhan. They all mentioned that with the improvement of the oxygen, improvement of the general condition, especially the ventilation, the patient's symptoms will get better. Even the troponin can be improved. So this kind of cardiac injury is induced by the systemic inflammation, but not the underlying coronary artery disease. So it's not advisable for sending those patients to the cath lab because at the danger of the medical staff. So
we agree totally. Yeah, we agree totally.
Yeah, this is a protocol from the Cardiology Society of China. So we have this protocol or the consensus. Yeah.
So to be clear, if a patient has a markedly elevated troponin, but they have no current of injury on their electrocardiogram, you would consider doing neither intervention nor thrombolysis. Right. If, however, they have current of injury, you would consider thrombolysis and only reserve coronary angiography and intervention for the very clear-cut, very dangerous, high-risk coronary presentations. Is that true?
Yes, very, very dangerous. So most priority is the thrombolysis for even acute myocardial infarction. Yeah, for this patient with COVID-19. So this is the consensus from our Society for Cardiology. Yeah.
Yeah, I think that's a very reasonable recommendation. Okay, so let's keep moving, and let's now invite Dr. Zhongtao Fu to present a second case. And if Dr. Wai or Dr. Zhao can tell us about Dr. Fu, where he's from, and welcome him.
Okay, dear professor from China, US.
Great, we can hear you well.
Can you hear me?
Yes, we can hear you great.
Okay. Hello everyone, I'm Zhongtao Du from Anjing Hospital. Because of COVID-19 problem, our ECMO team was sent to a designated hospital for COVID-19 in Beijing. Today, I report a COVID-19 patient with long-term ECMO support. This is the basic information. The patient is a 59 years old man. The height is 180 centimeter. The weight is 100 kilogram. The blood pressure, temperature, heart rate, and respiratory rate was normal when the patient admission to the hospital. From 2000 February 3rd, the patient has cover and fever, and the patient closely contacted with a COVID-19 patient from Wuhan on January 23 to 29, and the throat swab identified the novel coronavirus positive. So the patient was so the patient has been in hospital since February 4th. He declared that he had no previous history of disease. This is a CT scan. From the CT scan, we can see that there are many large segments of infiltrating saddle. But at this time, the patient's blood gas oxygenation is normal with oxygen inhalation by nasal catheter 3 liters per minute. This is basic treatment course. The patient used the oxygen storage mask 10 liters per minute on February 8th. February 9th, the patient used the tracheal intubation. February 15th, the VV ECMO was performed. February 20th, we used the tracheotomy for the patient. The February 24th, because we have enough nursing resources, so we use the position ventilation for the patient 12 hours a day. February 25, the bronchoscopic sputum aspiration every day. February 28, DRT was used. And March 14, the patient went from ECMO. February 9, 2020, the patient's dyspnea deteriorated. When the patient used the storage mask at 15 liters per minute, the SpO2 decreased to 70%. So intubation and invasive mechanical ventilation were used. On February 15, VV ECMO was initiated because the patient has a severe hypoxia. The PF ratio just only 50-54. On February 20, because we think the patients need a long-term tracheal intubation support, so we performed the percutaneous tracheotomy. This is the fiber optic bronchoscopy. From this picture, we can see the airway is normal. There is not much sputum, just a small amount of phlegm. We use the high-throughput sequence to test the bacteria. We use the sputum and the bronchoalveolar levis fluid as the sample to test. And the patient test found the Burkhardt species. We adjust the antibiotics according to bacterial culture and the clinical manifestations. Burkhardt species were found, and the ceftazidime avibatum sodium was used to control the infection. This is the lymphocyte count. We can see from the virus negative, the patient lymphocyte is above the normal level. This is the volume management during the ECMO support. The green curve is the cumulative fluid balance volume fluid. We can see during the ECMO support, the patient's volume management use the negative balance during the ECMO support. This is the pulmonary arterial pressure. We can see at the early stage, the patient's PP is normal. But from February 17, the PP was increased. We can see the February 26, the PP and the BNP were also high than before. So we use low pressure solution for inhalation, and we also use negative fluid balance for the patient. So 2 days later, the patient's BNP and the PP will also decrease. This is This is the macular injury marker. From the picture, we can see at the early stage, the patient's TI and myoglobin was higher than normal. But after February 9, the markers were decreased. We thought because as of February 9, we performed the tracheal intubation and the patient's hypoxia was improved. So the TI and myoglobin was decreased. This is the anticoagulation during the ECMO support. We use the ATT, APTT, and the D-dimer as the monitor indicators of coagulation. We use heparin for anticoagulation, but in the later stage, the platelet was low, so we changed the heparin to agatropine to prevent the heparin-induced thrombocytopenia. We can see from the picture, after we replaced the heparin with the agatropine, the patient's platelet was increased to normal. This is the ventilator parameter setting. The red curve is the tidal volume. We can see the tidal volume of the patient change with the patient's condition and gradually improve from March 4. This is the test film. From the test film, we can also see that the disease is improving, the condition is improvement. On March 12, the patient's general condition was better. We had a winning trial of ECMO. The patient's oxygenation is satisfactory, but the carbon dioxide level is high. March 13 results are similar with 12. So we prepared the carbon dioxide removal equipment ready for use for the patient. We had our third winning trial on March 14. This is the result of the trial on March 14. We see that the patient's oxygen is satisfactory and the carbon dioxide level can gradually decrease. The patient is in good condition after the ECMO winning. We also took the patient for CT on March 19 for examination. We can see there are many balloons for the patient in the both lungs. So much balloon in the lung. During the ECMO operation, it has basically normal, and the ECMO circuit was replaced twice because of the problem of the oxygenator. There was a small amount of bleeding, which was successfully stopped after compression treatment. So the patient is successfully weaned from the ECMO and the long term. During the ECMO, we found the oxygen improvement earlier than the oxygenated improvement. And back to the VCs. Thank you very much.
Thank you very much, Dr. Du. That was a very severe case. So how is the patient doing now? Is the patient weaned off from ECMO or is still on ECMO?
Right now, the patient is weaned from the ECMO for 29 days. But right now, the patient is also using the ventilator and not weaned from the ventilator. But right now, the patient is better than before. He can eat by himself on the bed. He can walk around the bed, but don't have wind from the ventilator. But the ventilator setting is very the setting parameter is very low. Maybe 7 days next week we can wind from the ventilator for the patient.
Yeah. That's a heroic effort of the physicians for this patient. That's a very long time the patient has been on ECMO, and a great great job, keeping your patients to maintain patient on ECMO for such a long time. Is there any role for left ventricular assist device in these patients? V to V ECMO, I understand, is if they have such a high BNP, would you consider adding an intra-aortic balloon pump or Impella or any device like that? Anyone in China has any experience like that?
Yeah. Can I have a very short comment?
Yes, please. Yeah.
In my ICU ward, I finished 4 IABP implementation bedside, but all of them died. All of these patients are suffering from acute myocardial infarction and also COVID-19 infection. So the problem is their implementation of IABP prolonged the survival days, just a couple days. But I don't think balloon pump is a very good choice for those very old or very, the condition is really very bad patient. Because
how about VAV?
Pardon?
How about VAV ECMO? You have a VAV
ECMO, yeah. VAV might the best one for those who have a very severe hypoxemia and a kind of heart failure and the acute myocardial infarction. That might be the best one. But so far, I don't know whether the Beijing district have this kind of cannula. In Wuhan, we don't have that kind of the catheter. And I consider to change the VA ECMO into a VAV ECMO for the second case, but I don't have that cannula. That's the point.
Yeah.
Maybe there might be those.
Yeah.
So I would be remiss if I didn't go back and echo what Dr. Dave said about that last case presented. That was an unbelievably heroic and complicated case, and you're to be congratulated on what was just a heroic and Herculean effort.
Good job, Dr. Du.
My question is, this particular patient had no risk factors, was 59 years of age. Can you speculate as to why this particular patient or any particular patient goes to that far end of the spectrum? Do you think it has something to do with initial viral load or exposure? Is there some factor that you could attach to this patient?
Yeah, so I think that what Dr. Cluck is talking about is the potential, prognostic indicators of these patients, which Professor Wang, who is, just recently finished her job in Wuhan, summarized very nicely: age, high troponin, cardiac biomarkers elevated. Those are, patients that appear to be the highest risk. Dr. Wang, can you summarize, the cardiac and prognostic markers once more time for our audience that, what should be raising the red flag for the physician that this patient will require mechanical ventilation, this patient will require potential ECMO insertion early. Would some of these biomarkers, should that be routinely checked, and would that help?
I think such kind of cardiac biomarker should be monitored carefully. Oh.
Okay, well, that sounds great. Yeah.
Can you hear me?
Yeah, I can hear you fine.
Oh, okay. So another one is if the troponin is very high, you have to pay more attention to decrease the preload and afterload of heart.
Okay. That makes sense. Yeah. Any other comments?
Yeah.
Yes, Dr. Ga.
Can you hear me? Yeah.
Yes, we can hear you fine. Yeah.
Yeah, it's pleasure to be shared so valuable experience from Dr. Zhou, Dr. Wang, and Dr. Du. I noticed that in these patients, especially severe or severe critical patients, they also have a condition, cardiac injury. In my clinical experience, I noticed that cardiac injury is a common and frequent condition in this severe or severe critical patients. I want to know how to distinguish from some coronary diseases such as NASTMI, especially as we all know that in some conditions, when these patients are supported by life support, we can't collect some data. It's not convenient to collect some data, such as obviously symptom. I want to know some experience from America. Thank you.
Yeah, I'm not sure that that data is just available just yet. So that data is being collected now, and we probably will have some data, in a few months, but not available just yet. Is that, Brian? Is that fair?
Yeah, I lost your video for a little while. I got your audio. Repeat it again, the question.
Is that, Dr. Gao, what was the main question?
Sometimes we can't distinguish the cardiac injury from NASTMI. Yeah.
Yeah. I think that's tough. That's tough. In my opinion, I think that we would probably have to assess based on the patient characteristic. So if the patient was elderly, patient had prior history of heart disease and had very high cardiac enzymes, then we may have to entertain the possibility of atherosclerotic plaque rupture and ischemic events. The question is, will I treat the ischemic event with a coronary intervention? Probably not. Try to manage them with medical therapy and try to correct the COVID-19 infection. And then they can always have angiography of their heart later on if that is possible. If the patient obviously goes into cardiogenic shock, that's very bad news, as Dr. Zhao from Tongji Hospital just explained. He had 3 or 4 cases of intra-aortic balloon pump placement, and all of those patients have died. So it's just unfortunate, I think, to have an ischemic event on top of COVID-19 infection.
Yeah, and I think that this is starting to come up a little bit more. On my last opportunity to be on call, there were a number of young people with clear-cut MIs. They were COVID-19 negative, but the staff still has to treat them as if they're COVID-19 positive. The complex donning and doffing of protective equipment is necessary. And here in the United States, we don't have a supply of protective equipment. And so for each of those cases that goes to the laboratory unnecessarily, we use up protective equipment, and that's been a real problem.
Yeah, no, that's a good point. Okay, I think this has been a great discussion. I want to thank all the very important physicians from China who has taken such a valuable time out of their busy schedule to spend this hour with us in creating the C3 and COVID-19 China experience session. So thanks everyone once again. We look forward to seeing all of you in June next year in Orlando at the C3 Congress. And I wish everyone a very happy evening. Dr. Yuji Zhao, do you have any final comments? Yeah.
So I'm very surprised and moving for our colleague to just to report that the case very challenging, very difficult. So our colleague, so this so real hero and real angel to help the patient. I hope the next year we give the great dedication for your C3 committee in Orlando. We are invited our colleague attend to your this the great meeting.
I appreciate that. Thank you very much. We will absolutely
special.
Yes, absolutely. That is wonderful to hear. Thanks, Y, for doing a lot of hard work to arrange this. I appreciate everything. And you all have a wonderful evening in China.
Thank you. Congratulations.
Bye.
Thank you.
Thank you very much. Thank you very much.
Salute everybody.
Thank you very much. All right. Take care. Yeah. Thank you.
Wishes.
Thank you.